Good afternoon. It's a great pleasure for me to be asked to participate in this very important Congress and these discussions with my dear friends from South America. It's been a great honor to be associated with you over all of these years, and I would like to start by appreciating everything you've done to help promote the risk score and do it to prevent the number one preventable cause, which is fatal pulmonary emboli. Now, in 1986, we started this journey with risk assessment. And since that time, people still don't understand certain facets of it. And I would like to go through some of those things today. And what's even more disturbing to me is there have been over 200 articles in over 5 million people in all 5 continents where my esteemed colleagues have taken a critical look at the score, the good, the bad, and the ugly. And where are all those results? The 2012, 2019 guidelines, first by Chest in 2012 and then Ash in 2019, there's nothing in there about all of your experiences worldwide. They're not all good experiences. There's some bad experiences. There's many lessons to be learned. All of us have to keep learning lessons and improving this process. So today, what I'd like to do with all of you is to share some thoughts and some reflections about this process, and also then touch a little bit on COVID-19. These are my disclosures. Now, the Caprini score has been chosen because it's the most comprehensive history and physical available today. And again, as I say, it's been studied all over the world. 40 elements are looked at, and we know that as the number of risk factors goes up, the incidence of blood clots increases. We also know there's a power of each risk factor. Some risk factors are weak power, such as birth control pills, and some are strong power, like cancer of the esophagus or pancreas. So these factors interact and in a synergistic way come up with a number, which includes the number of factors, their relative weights and powers. And then that number is a nonlinear increase in the incidence of venous thromboembolism as the score rises. As the score goes up, the incidence of venous thrombosis goes up. Here we see the results in general surgery. Now let's go back a page to Chest 2012. For the first time, the Chest Consensus Group acknowledged the importance of individual risk assessment, whereas 4 years earlier in 2008, they were against this particular score. But now by 2012, they stated that this score was one of the scores that should be considered, and they evaluated the scores, the 3 or 4 papers that were available then, and determined that a score of greater than 5 was associated with a 6% incidence of venous thrombosis. And this number has stuck till today. And it's inappropriate today. Fine, it was wonderful when they came up with it, some very brilliant people, but not anymore, things change. So I was very excited when the 2019 guidelines came out from the American Society of Hematology, who took over from the Chest group, because now we were going to see, at that time there were 150 articles in 2019, shows you how it's expanding. And I was waiting to see what they said. And they used the verbatim text, and I'd like to show you scoring systems that calculate the risk of postoperative VTE for individual patients with the Caprini score have been developed and validated following some surgical procedures, almost all surgical procedures by now. A widely used, highly quality guideline from the 2012 Chest, which places a strong emphasis on patients' VTE risk scores, is the Caprini score. Okay, they also mentioned the Caprini score in the same sentence as the Rogers score, which was also mentioned by Chest 2012. And there's only been 1 or 2 articles on the Rogers score, and that hasn't been adopted. The following reference was the 2005 disease a month. All the other references were missing. The meta-analysis was missing. So currently, we show that those with a score of 5 or more are high risk, but other patients with a score of 5 may be at very low risk. And let's take a look at these studies. For example, in general surgery, when the score is over 8, there's a higher incidence. In plastic surgery, over 8, it's 11%, whereas over 5, it's very low. And in head and neck surgery, practically nobody gets a clot with 5 or 6, whereas when it goes over 18, when it goes over 8, it's 18%. And you can see the populations in ICU. So the scoring system has various applications, but I'm going to show you the poster child for the United States. And if every hospital did this, we would literally wipe out venous thromboembolism within 30 days on the surgical services. This was a mandatory scoring system using the Caprini Score along with mobilization, but the key was there were various groups, and depending on the group, thrombosis was mandated, and that mandate required the surgeon to agree to it before the orders could be signed, unless for a reason they needed to opt out. They could always opt out. And if the score was less than 5, they had a variety of things they could do in the hospital, and everybody complied with that. But if the score was from 5 to 8, all of the patients got 7 to 10 days of low molecular weight heparin injections. And as you can see, 89% of the population followed that. And if the score was over 8, 9 and above, they got 30 days of low molecular weight heparin, and 3/4 of the patients went along with that. Now, what happened? In the beginning, there was a very high incidence of thrombosis, much higher than the national average, which we see here in green in those services. Adopting this protocol, by July 2013, the incidence was reduced to 0.1% of all VTE, including deaths at 30 days. And if all hospitals did this, you can see the kind of results they could get. Now, you might say, well, that's hard to do because this is probably a very famous hospital in a wealthy neighborhood where they could afford all of this, and the donut hole didn't mean anything to them. Wrong. This was an indigent hospital, and the authorities of the hospital got together with a drug company and made sure that every single patient that needed the drug got it for the period of time they needed without any charge if they couldn't afford it. Again, the poster child for the United States. Now let's take a look. I understand that not all 200 articles would have been candidates for this very elegantly done ASH guideline. I don't want to take anything away from the guideline. It was very elegantly done at the very highest level, and I applaud them for that. But this meta-analysis was left out. And Christopher Panucci, who wrote this meta-analysis, went out and got the original data sets from the papers that he was going to do the meta-analysis in. So he redid all of the data for himself, he and his group. So it's very good data. And what he showed was patients not receiving prophylaxis had a direct correlation between their score and VTE incidence, especially 7 and above. And not only that, patients with a score of 6 or less in this meta-analysis, in the 13 studies that were looked at, did not have a significant VTE reduction with chemoprophylaxis. Remember what Jess said in 2012, that patients with a score of over 5 had a 6% chance and should get prophylaxis. But now this is 2017. You see, believe me, I'm not trying to be critical. I love the CHEST guidelines. I love the ASH guidelines, but we have to keep up with new literature as it comes along. And all those with a patient score of 7 to 8 and over 8 had a significant VTE risk reduction using chemoprophylaxis. And the other thing that's really key about this is that if you didn't use prophylaxis, there was a 10% incidence of venous thromboembolism if your score was above 8. So that is a very powerful statement. Now let's go to Vietnam. 4 Vietnamese hospitals over a period of 2 years gathered 2 million, that's right, 2,795,024 patients. And look, we see the same things happening. As the score goes up, the risk goes up and is the highest over 8. Now let's go to China. And here we see patients this is a lung cancer population. That low score, they didn't get a clot. A moderate score, 5 to 8, 12% incidence. It jumped to 40% when the risk goes to 9. Lessons we're learning from all of our wonderful colleagues from around the world. And these studies are very consistent from country to country when they were done right. And they are to be believed. Now let's go to Russia. Cyril Lobostov and his associates. They had a very high risk population, and they scanned these people. And when the patients had a score of 5 to 8, there was one scan clot. But if the patients had a score of 12 to 15, there were 65% of them had a clot. That doesn't mean they were all statistically significant clinically. But what that shows you is with escalating score, there's an increase in the incidence of thromboembolism. And not only that, but you have to look at your own particular population. This Moscow hospital, these patients were very seriously ill and had very complicated procedures. So you have to take a look at that when you look at these results. Now, here's another thing which is absolutely critical. And these patients, this is another study that was done by Lobostov and his associates. And they said that patients who had a score of over 9, the symptomatic VTE incidence, now this is symptomatic, was at least 11%. And in those when the scores were 11% or greater, the incidence of symptomatic events approached 59%, despite the combination of stockings and low molecular weight heparin. So they postulated that this extremely high-risk group required improvements in their VTE prevention protocol, and escalating the low molecular weight heparin dose was one option, but that could lead to more bleeding. So they decided to do a group where they would compare this group to a group that received pneumatic compression in addition. 407 patients randomized to be their control group, low molecular weight heparin stockings, or low molecular weight heparin stockings adding the pneumatic compression. All patients underwent blinded duplex scans preoperatively, 12 hours postoperatively, and every 3 to 5 days. Low molecular weight heparin prophylaxis was given for at least 7 days or more in all patients, as has been shown over a 30-year period from all the trials. And IPC was used for 18 hours daily. The duplex ultrasound revealed that the symptomatic venous thrombosis in the lower limbs was seen in one patient who was in the combined group with the pneumatic compression, and 34 patients in the group that did not get the pneumatic compression. Remember, everybody got low molecular weight heparin for 7 days. So 5 of the patients in the control group, low molecular weight heparin only, developed PE, and 3 of them died. No PE were seen in the study group combining pneumatic compression with low molecular weight heparin. No statistically significant differences were observed regarding skin injury, bleeding incidents, or PE-related mortality or postoperative mortality. Isn't that a fascinating study? Let's go back to China and let's talk about burns. And burn patients have a very low incidence, as you can see around when the score is around 5 to 6. But look what happens. It gets up almost to 9% when the score goes above 8. Are we seeing something here unique? Of course we're not. In all of these countries, with all of these wonderful investigators around the world, the score goes up in proportion to the type of population being studied, and the highest score only begins at 5. It goes much higher in certain populations. Now let's take another look at another study that was done in head and neck patients. And those patients in this study who had a score of 6 or less, nobody had a clot. Whereas when the score was over 8, then there was a very high incidence of thrombosis, and it got even higher when the score went over 10. So look at the set points in this population, totally different population. Chest 2012, ASH 2019. Are you listening? All right, let's go back to China. And here we see a comparison of patients at risk using both the Caprini Risk Score and the Padua Risk Score. And look at this, with patients with a score of 5 to 6, a 3.3-fold increase in the incidence of VTE, 9.4-fold 7 to 8, and 24.69 if the score was over 9. Set points, we're seeing the same thing. Different country, different populations, different groups, same thing. And then besides that, between cases and controls, highly statistically significant sensitivity of the Caprini score of 80% compared to Padua score of 30%. Interesting data, isn't it? Now let's talk about, now we're going to go to Thailand. And this is a very important study in hip fracture patients. And they were having a lot of clots, so they decided to scan everybody ahead of time. And they also used a well score and D-dimer. But the real punchline of this study is that they found that 16% of the patients who came in with a hip fracture had a duplex scan positive preoperatively. And the sensitivity and specificity of the Caprini score was high. And therefore, and also here's another thing. If the score was over 13, equal to 13, there was a 60 or 73% chance that patient would have a clot. So the authors recommended that all patients with a Caprini score of equal to or greater than 12 be screened preoperatively, which has been poo-pooed in orthopedic surgery. But now we're talking about hip fractures. And in this particular locality, in this particular situation, that's what it held true. More interesting data. And now we go back to New York, where they did a study of 1,078 patients over a 15-month period. And the 7 orthopedic surgeons who did hips and knees combined to do this protocol, and they had a department protocol, and they had their criteria for high risk, which were what a lot of orthopedists use. There are a few criteria. And when they looked at the results, everybody who was not considered high risk in their protocol got aspirin. And what happened was that in the department low risk, there were 7 patients out of the group. 7 of the 8 patients in the study that got a clot were classified as low risk by the department protocol, exactly parametrically opposed to what the Caprini score showed, all but 1 patient. The Caprini scores were done in retrospect after the original data was done. They went back and rescored the patients, and they found that 7 of the 8 patients were positively identified with a score of above 10. The orthopedists have yet to accept this. Since that time, they published an additional study where their incidence over 1 year was 0.2%. So it's more and more interesting data. So in conclusion to the risk assessment part of this talk, the risk score increases in direct proportion to the incidence of clinically relevant VTE events. Identifying those at high risk varies according to the population tested, and the original concept that everyone with a score of 5+ is no longer true. As a matter of fact, in head and neck surgery, nobody had a clot in that one study. Some patients with a score of 5 or 6 may be spared anticoagulants according to the meta-analysis, if you fit that one of those trials where the meta-analysis was done. And the set point for high-risk patients needing prophylaxis, as I've shown you, varies around the world, varies with different populations, but the relative results and the relative risk reduction is similar all over the world. Now let's just briefly talk about COVID-19, and this is a very complex, multifaceted, serious infection. One of the things that one of the few good things about this is that I've been able to reach out to my colleagues around the world much more frequently because I'm just sitting here in my den, and I love that. Anyway, this disease results in activation. As we know, before COVID, Hegeman factor could activate platelets to produce plugs, coagulation to produce fibrin mesh, fibrinolysis to stimulate blood lysis, and then activate the complement and kallikrein systems, the inflammatory and antigen antibody or antigenic systems, immunologic systems, without an antigen antibody reaction, all mediated through Hegeman factor. COVID-19 is this constellation on steroids, as it were. It magnifies it 100%. There's a predilection for the lungs, and Oscar Ratnoff made some very important observations that, you know, as a part of this whole thing, we see thrombosis, fibrinolysis, increased vascular permeability, vasodilatation, bradycardia, angioedema, histamine release, and hypotension. And these are all interrelated facets, and the body looks at them as a whole, like pieces of a jigsaw puzzle, fitting into the whole puzzle. And individual pieces are fascinating, but that isn't what makes up the puzzle. And to note, and just to point out, unfortunately, although there's a lot of thrombosis with the disease, anticoagulation alone is not the answer. Now let's go forward here now to the NIH multi-platform. And it was announced on January 22nd that in severely ill patients, this is a worldwide study, very large, very well done study. In seriously ill patients, meaning they're in ICU or on or off a respirator, escalating the dose of anticoagulation did not help, and there was just more bleeding. But in the moderate risk patients, that means they're in the hospital, but they are not, of course, they're not in ICU, that the need for organ support and mortality was better, was superior, using full anticoagulation compared to the usual care. And this harkens back to a principle that we put together with some of my brilliant colleagues from the American Venous Forum. And we decided, and this was when they were still debating whether or not, when patients come into the hospital with COVID, should they get low molecular weight heparin, and we heparin or low molecular weight heparin. We said they all should, but you got to score them. And that's still not being done in most of these studies. And if the score is over 8, then you double the dose of anticoagulation. And then rescore at discharge, and then use extended chemical prophylaxis for patients which have those criteria listed here, like elevated D-dimer, BMI, other Caprini score factors. We also decided to introduce this as a straw man for all of you around the world to, if you will, knock it down. And we decided that because of the thrombosis potential in this disease, we would add 2 points for COVID positivity, add another point if they're symptomatic, and add 2 more points for a total of 5 if the D-dimer was positive. And then we also emphasize that this has to be updated during hospitalization. So here we go back again to Russia, to this wonderful Moscow group with Cyril Lobostov and his associates. And they looked at 168 patients with a Caprini score, and they identified a significant correlation between the Caprini score and the risk of VTE in COVID-19 patients. That's the regular Caprini score. They did a variety of models, including the new model, which I proposed. And they concluded that the original model was appropriate enough for COVID-19 patients, and they didn't see any real advantage to use the additional model that I proposed. Now we go to Egypt, and this is just out. This is not fully published. It's just in a newsletter. But these investigators studied the direct correlation between the Caprini score and the risk of VTE in COVID-19 patients. And the score equal to or greater than 7 calculated in admission, or 11 or more at discharge, predicts symptomatic venous thromboembolism despite pharmacologic prophylaxis, intimating that maybe we need to increase the doses. The predictability of the original score may be improved by implementation of the D-dimer or the specific COVID-19 points that I proposed. However, the original Caprini score is essential. So what we're seeing with these 2 studies is, for goodness sake, do the original Caprini score, because that works. Whether or not those additional scoring factors that I proposed are going to work out in the end, time will tell. But we have all these wonderful investigators from around the world that are willing to test this. Why? Very simple. To stamp out as much as possible the #1 preventable cause after surgery or hospitalization, fatal pulmonary emboli. Now, my hat's off, and I'd like to give special acknowledgement to my dear friend Alex Preoperative, because he is doing scoring in COVID-19. And he came up with a study, as you can see here, of 4,960 patients, continuing anticoagulation after discharge in 13% of these patients, significantly lowered the composite outcome shown above by 46%. Comorbidities, hypertension, diabetes, obesity, and cancer history. And he used his improved D-dimer score of over 4, which was one of the most important predictors of VTE risk. Hats off, Alex. God bless you and the work you do, and keep it up, because you know what? We're all on the same page. There are many roads to Rome. So in conclusion, I want to quote from my dear friend in Maine: "Never kill a friend, never treat a stranger." And what we mean by that is that when you meet somebody, you do a thorough history and physical, and in so doing, they become almost like your friend. And then, of course, you would never kill a good friend, but don't ever treat a stranger. Particularly important exercise, especially during COVID-19. I'd like to thank you all for your attention. Please view my social media platforms for more information.